So good morning. Hi. I always say it's nice to see you all. Of course, I can't see you, but I know you're all there. So welcome to our webinar this morning, which is Dementia 101. And we are from Alzheimer's San Diego. We are going to be talking about Alzheimer's disease and some of the other types of dementia that people may either be encountering in friends or family members, people you care for and love, and that folks individually may be experiencing. And we'll be talking about those symptoms as well too. In regards to the symptoms, we're going to talk about, what are the risk factors that can lead to dementias and how do we do our best to manage those risk factors. We will be talking about screening. How do we start this whole process of understanding, is there something going on with myself or somebody I care about? And then how do we get a diagnosis and what does that look like? Disease progression we'll be talking about just in general terms for dementia, not for any very specific type of dementia. Symptom management will be another area that we'll be covering. And then we'll be concluding with some discussion on planning, which will cover safety, well-being, and support for any and all of us, either as people who may be living with a diagnosis of some type of dementia and or people who are caring for or living with somebody with dementia. Our whole goal here is to really provide everyone with how we describe is foundational knowledge about Alzheimer's disease and other types of dementia, so that you've got a good basic understanding of what these terms mean, what is the knowledge behind it, what's going on, so that you're able to build on your knowledge as you go along. That's really important if you have received a diagnosis of dementia or Alzheimer's disease, to have some good basic understanding of things so you know the right questions to ask and so you know where to go to seek out your information. All right, so we'll start here with Alzheimer's disease and related dementias. So look at this slide. I like it. It's kind of all over the place, but that's kind of where we're going to start, because dementia is a word that kind of takes us all over the place. And there's all sorts of other language and words and terms and descriptors that fall into it, just as you see here. What is it? Forgetfulness. What's Lewy body? What is that all about? How does the hippocampus play into this? Mixed dimension. What is that about? Young onset. What does that mean? So these are all kind of in the mix of this word dementia, and we want to try and dial it down a little bit and see if we can come to a better understanding of all these things and have a little bit more precise and cohesive area of knowledge around the dementia that is maybe impacting ourselves or somebody we care about, our family. So we want to talk a little bit of what is some terminology that we need to know about. And we're going to start here with mild cognitive impairment. This is also sometimes referred to as minor neurocognitive disorder. And the shortened form that you may often hear, especially health professionals such as ourselves using, is MCI. Have any of you folks heard of that? He or she has MCI, or that's the diagnosis. Mild cognitive impairment is its own diagnosis, and it is diagnosed when a person is dealing with, on a daily basis, memory or cognitive changes that don't interfere with daily function, with their ability to do the things they need to do on a daily basis. But it is to an extent that it is noticeable, that either by the person experiencing it or by other people. who are witnessing it, and they're seeing either these, lapses in memory or changes in other areas of cognition that are quite apparent, but not significant enough to impact daily life. So that is what MCI, or mild cognitive impairment, or minor neurocognitive disorder, is all about. So on the other end of the scale here, we have dementia, or major neurocognitive disorder. In this instance, a diagnosis of dementia, or a diagnosis, I should say, of some type of dementia, is reached when a person is experiencing symptoms that is affecting their daily function in a very significant manner. And it is caused by some underlying medical condition, and there are a few of them that could be causing it. And it's impairing people's ability to function well in the areas of memory, language, visual perception, problem solving, and attention. So just to illustrate again, the significant difference between dementia, or major neurocognitive disorder, and MCI is that in this instant, it's affecting at least two of these areas we've talked about: memory, language, visual perception, problem solving, etc. At least two of these areas, and in a significant manner, versus mild cognitive impairment, where there's visible change or apparent change, but it's not a significant impact. So I hope that makes sense, that we've made the distinction between the two. It's important. What else would I say about dementia? An important thing there is that some of the symptoms of dementia may be reversible, and we're going to get into that a little bit more a little bit later. Now, Alzheimer's disease. What is Alzheimer's disease? Well, it is a type of dementia, and it is the most common type, and it is irreversible. It is progressive, and it is the most common cause of dementia for about 60% of people diagnosed with some type of dementia. Unfortunately, at this point in time, we do not have a cure for Alzheimer's disease. And there is no treatment that is disease modifying, although symptoms can be treated. And we'll be talking about what that looks like a little bit later on here this morning. So, last, we want to just mention young onset dementia. And this is a form of dementia. Amy, correct me if I'm wrong, but isn't it affect about 10% of people with dementia? Yeah, about 10%. And this is the terms that we use to describe forms of dementia that are impacting people with symptoms appearing between a person's age of 30s to mid-60s. So in that age range is how we would term a younger onset dementia. And it is, again, its own diagnosis, as I suspect many of you can envision. There are all sorts of different impacts on a person's life when you are at that young age and being diagnosed with dementia. Oftentimes our folks in that particular group may still have either young children at home or perhaps college-age children that they're still financially supporting. We're still oftentimes still working and working towards retirement. So it's just a whole different set of circumstances and challenges for folks living with younger onset dementia. Okay, so again, this is really important information for all of you, is that there are many treatable causes of cognitive change. And by treatable, let's just change that word out and say reversible. That's the thing. And the key important takeaway with this. So with all of these different conditions that are listed, depression, illness, infection, anything of a medication reaction, dehydration or malnutrition, poor sleep, stress, or sensory loss, there's a whole set of symptoms that a person may experience with each or any of these that is very similar to the symptoms of dementia. So what are we talking about? Okay, well, I want you to all think maybe about one of these things or more that you have experienced. What happens when you don't get a good night's sleep? How are you the next day? Do you think clearly, or are you foggy? Personally, I can tell you, for sure I'm foggy, and I'm probably cranky too. Depression has some similar things, what we call the foggy brain, and people with depression often find it difficult to make decisions. They may have a sense of inertia and a lack of initiative to get things going. And those are symptoms that we often see in dementia as well. Just think about if you've been really sick. Most certainly, our folks who have had COVID-19, who have recovered, have, they're facing some challenges in cognition upon recovery because of the illness that they have had and the fever and, all these different things that have been going on. And, with regards to dehydration or malnutrition, I think oftentimes just think about myself when I start to feel really hungry and I haven't eaten for a while. I get what I think they call on the commercials, I get hangry. So I start to get irritable. And, it's a cognitive change that I experience when I'm feeling hungry. Stress and sensory loss, these are all things, again, that affect our cognition. When we're feeling really stressed out, the ability to think clearly and process information and make good decisions is impacted. And with sensory loss, I just think oftentimes about actually my uncle who had significant hearing loss and refused to wear hearing aids in his later years. And he missed out on so much information. And when you think about that, if you're missing out on important information, that is limiting your ability to act on it or make good decisions because you're lacking that information. So that's affecting your cognition as well too. So these are all treatable things though. So, we can see our doctors and there's medications for depression, there's medications for infections. Dehydration or malnutrition can be monitored and reversed. Inadequate sleep, there's some different things you can do that it's not always about medication. Things you can do to try and get better sleep. Stress, there's all sorts of things we can do there too. Everything from meditation to maybe some talk therapy or just building our support systems. And sensory loss, we can get hearing aids that are not overly complex or annoying. So there's things we can do here. Boy. Now my screen's just not wanting to advance, and then it advances several times. Amy, I don't know if you can help me out here. It's just not working for me.
Okay, I'll take the remote back and see if this is where you want to be.
Yes, please. So, and thank you, Amy. Dementia
Sure.
is not a specific disease, not a singular disease. There are many types. And as we mentioned earlier, Alzheimer's disease is the most common one, and that's going to account for the bigger part of the pie here, which is, 60 to 80% of dementias. And Amy, I'll just ask you to advance the slides for me if you would. Thank you.
You got it.
And then here in the other corner of the pie, we've got the other non-Alzheimer's dementias. And we've got them listed in order of how common they are percentage-wise. And Lewy body dementia is the next most common type of dementia after Alzheimer's disease. And it has a specific pathology to it as well too, where proteins that are called Lewy bodies are forming in the brain and affecting memory and cognition. And vascular cognitive impairment is next on the list, and just as it suggests, it's closely linked with cardiovascular diseases and conditions that are affecting blood flow in the heart and therefore affecting the brain as well too. There are frontal temporal disorders, and there's a variety of them as well too. And just as that name suggests, these disorders are impacting the frontal lobe of the brain, so they also present with some rather unique characteristics. Mixed dementias are more common, probably more common than we have understood so far. And mixed dementia meaning a person has two or more types of dementia. And there are other dementias as well. So that is, again, an important takeaway, is to understand dementia is not just one thing. It can be many things. It can be some differences as well too. There are differences in terms of the recommended, for example, medications for people with Alzheimer's disease versus people with Lewy body dementia. So, and these can be important and have great impact on quality of life for people. So keep that in mind. We're going to now just make some mention here of the gentleman who discovered Alzheimer's disease. And that's his picture there, Dr. Alois Alzheimer. And he discovered the disease in patient Auguste D in, I think, 1906. And Dr. Alzheimer was a neuropathologist, and he followed the case of this lady, Auguste D, who presented at a young age with all sorts of strange symptoms, hallucinations, and behavior issues, and significant cognitive issues, and all sorts of things going on that they were having some trouble figuring out. She did eventually die with this disease that at that time the people were, we didn't have a name for it and didn't really know what had happened with her. And as a pathologist, Dr. Alzheimer asked if he could do an autopsy of Auguste D's brain, and so he did. And what he discovered is these beta amyloid proteins that we call plaques, and the tau proteins that we call tangles. The plaque forms between the brain nerve cells, and then the tangles, the tau tangles, form inside the neurons. And so in the one big slide at the back here, those kind of yellowish clumps that you see would be representative of the plaque that is forming. And then the tau is actually inside the neurons. And so this is not only disrupting communication between the neurons, the brain cells, it is also causing cell death. And so if that's happening, there's damage being done in the brain. The brain cells aren't working either together or alone the way they are supposed to be. So that's what was discovered. Then this small slide here at the bottom is just giving you the illustration of what healthy brain cells would look like. So that is kind of the pathology behind Alzheimer's disease. So with regards to how is the brain affected, what I want you to see here in this slide is this cross-section on the left side of what normal brain tissue would look like. And on the right side is a cross-section of Alzheimer's brain tissue. And you can see there's visibly significant change between the two. All sorts of kind of gaps where, you know, the brain has, the mass of the brain has atrophied, it's shrunk. And we see these big kind of spaces that have opened up. And, you know, on the right side, it's kind of how I describe it is plump. You know, it's healthy. We don't see many gaps or crevices there versus on the right side. And I want to point out this, you know, big kind of open space in the Alzheimer's brain tissue that the arrow is pointing to. And that is the area of the brain where the hippocampus sits. And we can see there's no tissue there at all in this cross section. And that is significant because the hippocampus is a very important organ in the brain that is really kind of the seat of where our memory is processed, is encoded, is stored. So all those things that come in, all that information that comes into our brain is processed in the hippocampus and then gets sorted out accordingly from there. And if that's not working, that's why we have memory impairment. That's why memory loss is a very common and often significant symptom that we see in many folks with dementia. So then a quick kind of overview of the brain and the areas of the brain and what's going on is depicted here. Now, as it says here on the slide, each type of dementia affects the brain differently. And so think back when I was talking about frontal lobe dementias. Those dementias are often, at least initially in the disease, the damage and the area of the brain affected is in the frontal lobe, which is, you know, depicted here in orange. And, you know, other types of dementia may have damage and change occurring in other areas. Universally, most dementias are going to experience, most people who've been diagnosed with a dementia are going to experience, you know, global change in the brain over time. We just want to note that different types of dementia, how the disease is progressing from damage in one area to another, there may be differences there. All these different lobes, I want to point out, you know, have different roles in what they do for us. And so I mentioned the hippocampus, and just to let you know, in this particular diagram, the hippocampus is in the temporal lobe. So right down in there. And not only memory processed in the temporal lobe, but language as well too, which is why we often see people with dementia experiencing some language difficulties. The frontal lobe is responsible for what we often call our executive function. So our decision making using good judgment, behavior, problem solving, that kind of thing going on is governed by the frontal lobe. So that's, if we see damage there, that translates into, you know, potentially poor decisions and being vulnerable to scams because of, you know, poor judgment, other things like that going on. The blue area is the parietal lobe. And in the parietal lobe, we have our sensory system governed, so our perception, as well as our word and thought formation. And the occipital lobe, the yellow in the back, is governing vision. I will say our brains aren't actually our different lobes aren't actually those colors. That's just for illustration's sake. I think pretty much it's just kind of a nice pinkish grayish mash. No blue, no green, no yellow. Okay. All right. Let's see. We've gone through now.
Launch this poll real quick,
Oh,
Jean.
absolutely. Yes, we do have a poll. So
We're going to keep you on your toes here. Yeah. Has it popped up? Can you see it?
I don't see it.
Okay, here we go.
I do now.
Wonderful. Okay, quick question for all of you. You can, using your own mouse, use your controls, answer this question. Which structure in the temporal lobe of the brain plays a major role in learning and memory? Is it your amygdala, your hippocampus, or your white matter? Fair number of votes coming in. Keep them coming. Great. Okay, I'll close it here in a moment. I'll let you see the results. Okay, most of you have voted, so I'm going to go ahead and close the poll. Thank you for your responses. It looks like the hippocampus is a clear winner of the poll. Jean?
Woohoo! That means you are all paying attention. That's good.
Yes. 87% of you got the correct answer. The hippocampus is the little structure within the temporal lobe of the brain that plays a major role in human learning and memory.
Yes.
Great.
Excellent.
Thank you. Thanks for participating, everyone. Go away.
Okay, let's move on here. So the good results for everybody, almost everybody, shows that I think we've ticked, just as it shows on the slide, we've ticked that part of our agenda off for this morning regarding covering Alzheimer's disease and related dementias. So let's move on and talk about symptoms.
Just a quick reminder, if you have any questions, go ahead and type them into that Q&A box, and we will be pausing to answer some questions in a few minutes.
Great. All right, so here's a big question. We're going to talk about normal age-related changes in cognition versus symptoms of dementia. How many of you folks are, I've made you anxious just by asking this question, and or it's like something you really, really want to know about? Feel free to throw some answers in chat there. I suspect it's a significant amount of people. So here's the good news. Take a deep breath. So what we're talking about is, with symptoms of dementia, what we're seeing is a marked change from baseline for a person. So what is baseline? Baseline is normal. Normal for you, normal for me. So what's normal for you and what's normal for me can be different. And so, for example, I have often told people this, you may have heard it from me yourself, is that my working memory is very poor. If you, I ask you for your phone number because I'll call you later, and you tell me your phone number, I'll get the area code and the first 3 digits, but I'll have lost the last 4 digits of your phone number, like instantly. And that's normal for me. So that's not something that I'm worried about. Other people are really good with working memory. So it's really important to have a good knowledge of and understanding what your normal is. Symptoms of dementia will be significant enough to interfere with daily activities. So let me just say, I am on a constant journey through whatever environment I'm in right now. It's in my house, has been for several months. on a constant journey through my house looking for my phone and or my glasses. And it's annoying, and there's some days I might say it kind of interferes, but really it's not significant. So we are talking about things that are significant enough to affect daily activities. I always find at least a pair of glasses. And so that's fine. If I couldn't find, and honestly, folks, I probably have 10 or 12 pairs of glasses. And so if I couldn't find 10 or 12 pairs, then that would be significant and I'd be in trouble then. So you have to really kind of think that through. The other thing is symptoms of dementia are affecting 2 or more domains. Memory, oftentimes memory, just as we talked about with the hippocampus being affected. Memory can become, short-term memory in particular, can become really impacted. Thinking, just the process of cognition, processing information, responding, thinking things through, problem solving. The physical domain, meaning everything from fine motor skills to balance and coordination. And then there is behavior as well too. And we're going to delve into all of these. Okay, so let's start with memory. Well, what would be normal age-related changes? The things I just talked about with regards to my journey for my glasses. Other normal age-related changes would be more difficulty remembering names or finding words. I do that on a semi-regular basis. I wonder if some of you do as well too, where you're trying to remember maybe the name of a person to tell your spouse about that person. And for myself, I can provide all sorts of detail about the person, but I can't come up with the name. It eventually comes to me, but that's not a concern. That's a pretty typical age-related change. And then again, the misplacing objects, which I talked about with my glasses, and for other people, it's their car keys or whatever it might be, wallet. But we do, we've got the ability to retrace our steps and find these things. So with dementia, how is memory affected? Well, in a much more significant way. And that may mean getting lost in familiar places, in your own neighborhood, going off to your grocery store and getting lost, trying to get your way back home again, or forgetting where a particular store is that is a place that you've frequented all along here. And then forgetting the function of objects, which could be everything from not being certain, is a remote for the TV? Is that black oblong thing for the TV, or is it a phone? Or what is it? What does that object do? Having some challenges with those types of things would be a symptom of dementia, that, something maybe else is going on. It's not a normal age-related change. With thinking, there we go. A normal age-related change is that we are slower at an older age to learn new things or to problem solve. And it's just because our neurons, there's all sorts of reasons for it, but one of the reasons is our neurons, our brain cells are not at peak efficiency anymore. For me, in my later 50s, as compared to when I was 25, my cognition itself hasn't changed. It's just slower. The processing is slower. And so I have to pay closer attention and just kind of put a little bit more energy into it to be able to learn new things and solve problems. Normal age-related change is also changes in attention or concentration. And I always like this one that I read several months ago, that a person said when they're in their car, they have to turn the music down in order to see better. And that's a perfect example of the changes we have, normal age-related changes in attention. With dementia, there may be some significant difficulties with all these things: language, reading, writing, or working with numbers. It just becomes much more difficult to be able to do things like keep track of accounts, finances. Some people may have trouble with reading, being able to have the brain process the written word. And we also see changes in judgment, insight, or reason. And that's one of the chief reasons why we get concerned about our folks with dementia, because they become vulnerable to scams. And in addition to that, it can be safety concerns as well too. Physically, the normal age-related changes we see are, as we know, vision, hearing, and other sensory loss is part of what we're experiencing. And that is, as I mentioned with my uncle, it's impacting our ability to take in information and respond accordingly. And we do have reduced strength and flexibility as well too. For folks with dementia, they have oftentimes some significant change in the visual field. It becomes quite narrowed with dementia. And they may be having problems also then with balance and coordination, which is why we tend to see more falls in people with dementia or the symptoms of dementia. Behavior-wise, changes in behavior are not a normal part of aging. We are who we are. I'll channel Popeye, the Sailor Man, for a minute. He sang that song. He said, "I am what I am," and that's what I am. And really, who we kind of are personality-wise doesn't really change much over time, right? If you're a wise old soul from a young age, you're kind of a wise old soul for the rest of your years. If you're a cranky bugger, then you're kind of a cranky bugger. So that doesn't really change. But in folks with dementia, there can be some real significant personality change with mood, with social withdrawal, with difficulty initiating tasks, with initiating almost all things, as a matter of fact, and just changes in normal daily routines. And these changes in behavior can be positive or negative. And I've worked with many families on either side of that coin. It does tend to be that when the changes are on the negative are the majority of the families we're hearing from, because if it's been a positive change, you may not be needing to call us for some help so much. So, but these are the things that do happen. So let's just move on here and then talk about the risk factors and screening and diagnosis. So this is our numbers slide, and these numbers are important. We'll take just a bit of time with them because I want you all to understand the significance of what a major public health concern Alzheimer's disease and other dementias are for all of us. If you have been lucky enough to this point in your life that nobody you know or love or care for has been impacted by Alzheimer's disease or another type of dementia, you are still being impacted in other ways. So here we have it. 5.8 million Americans are living with Alzheimer's disease. And that's a number that is verified through diagnosis. So how many people are actually living with Alzheimer's disease? Folks that haven't been diagnosed? It's a much higher number, people, for sure. Dementia affects 1 out of 9 people over the age of 65, and that risk increases as we get older. In San Diego County, the latest figure that we got is that nearly 84,000 people here in San Diego County have been diagnosed with Alzheimer's disease. And again, we're talking about verifiable diagnosis. So we know that that number is larger of people that are out there living with dementia. It's the third leading cause of death here in San Diego County. And it clearly takes a significant emotional, physical, and financial toll. So it's impacting society broadly. And these numbers give, credence and validity to the fact that it is a major public health concern. What are the risk factors? These are some of them. Age is the number one risk factor, which is why it's kind of up at the top in a darker blue. The older we get, the more likely we are to develop dementia. So 1 in 9 people at age 65, that number drops to 1 in 3, almost 1 in 2 people by age 85 are developing some type of dementia. Sex, unfortunately, females are impacted more by Alzheimer's disease and dementia than males. And research is still looking at, the particulars behind that. Health factors such as hypertension, heart disease, diabetes, and hearing loss are all risk factors for developing dementia. There are genetics and family history. And by the way, those are 2 different areas. I mean, there can be genetics involved as a risk factor, and there can be family history involved as a risk factor. So there's kind of 2 things going on there. Education level is a risk factor, and the less formal education a person has, the higher the risk for developing dementia. Head traumas of many types, and including loss of consciousness and concussion, are all risk factors for developing dementia. And Down syndrome is also a risk factor because of the particular biomarkers that people with Down syndrome have. So these all up the risk factors. There are ethnic disparities. We do see more numbers of Hispanics, or I guess the new term is Latinx. Did I pronounce that correct, Amy?
Latinx, yes.
Yes, thank you. And also African American folks have higher risk factors of developing dementia. There's no known environmental risk factors or causes at this point in time. So, all right, don't look at the slide yet. How do we lower? You can put it over, Amy, I'm teasing. But how do we lower our risk factor? What do you think we need to do, folks, to lower our risk factors? Yes, all these good things on the slide that, we knew about, didn't we? Really, most of them we did. Good diet, good nutrition, get our regular exercise and physical activity. Get our intellectual activity, challenge our brains. However we do that, whether that's doing the crossword puzzle or playing cards or learning how to speak a new language, even if we don't do it very well, whatever it is, we're challenging our brains. We keep our social connections, super important. I would wager a guess that many of us have really felt the change and the limitation in our social connections over these past few months of sheltering in place. And it's not particularly good for us. It's important for safety right now, but it's not particularly good for us. We are wired to be together, to be social, to be engaged with one another. Our emotional health needs to be attended to in terms of watching out for depression, anxiety, high stress levels. And we need to do all we can to try and get a quality sleep, which is a problem for many people. And, there's all sorts of information devoted to good sleep hygiene and the steps we need to take in order to better achieve that. It's important to just remember that what's good for your heart is good for your brain. For any of these things of managing risk factors, let me just say, if you're having trouble in any of those areas, you need a little extra help or a little boost, give us a call at Alzheimer's San Diego, and we can maybe come work together with you to come up with some ideas to make some of those changes. So we talked about screening earlier, talking about understanding one's baseline, what is normal for you. So this is why it's great to, at this point in time, I think your best bet would be to see your primary care provider for a memory screening. And this is a fairly short screening tool that primary care physicians use and other organizations use to establish your baseline. And it's some pen and paper questions and some verbal questions, and it just gives us an idea of where your cognition and memory are at. It's the kind of thing you want to do on a good day, not on a day where you haven't gotten any sleep last night, because we want to see what's kind of normal. So not having a good night's sleep, if that's unusual, then you're not presenting as kind of normal for yourself that day. So then why do we do this? We've got this baseline. Why? Well, then it can become part of your regular yearly wellness check, so that we are detecting changes early. If there is a change in how this screening goes from this year to next, let's look at it a little further. Why is that happening? And it's not necessarily that it's Alzheimer's disease. Again, it might just be, was just a tough day for you. Or maybe there's something else going on. Is there maybe some depression starting to occur and needs to be addressed? We want to do these things and catch these things early because we do want to rule out these reversible causes of memory change. If my thyroid is not operating correctly, I am likely to have a change in my cognition and my memory, which could be reflected in my screening. Oh, something's going on. Well, guess maybe I'll get some routine blood work and look, my thyroid's not working. That's got a pretty easy fix, and it's a medication that you take once a day. So we want to absolutely figure out these reversible causes of memory change. What else is important with early diagnosis, detection and accurate diagnosis is that it gives people time to be thinking about appropriate treatment and planning, care planning, looking forward to the future. If I am diagnosed today with Alzheimer's disease, that gives me time to think about how I want my life to unfold living with Alzheimer's disease, who I want involved in my life, what roles I want them to play. It gives me time to tell people, if I haven't already, what is important to me. How do I want my end of life? How do I want that to look like? What are the pieces and the people and the places that are significant? And it gives me time to voice that now, because knowing that with a diagnosis of Alzheimer's disease, my ability to voice that is going to change over time. So these are important discussions to have now, to have today. Medication, the medications that are used to treat the symptoms of Alzheimer's disease and some other types of dementia are more effective when started early. So early detection and diagnosis gives time for these medications to have positive impact on quality of life. Time for advanced planning, as I referred to already, and also greater opportunity to participate in clinical trials, which many of our families and our people living with a diagnosis of dementia find to be very empowering, it's a powerful tool at their hand to be able to be contributing to research that, we often say the first person cured of Alzheimer's disease is going to be somebody, if not already somebody, who's enrolled in a clinical trial. Just think about the power of those words and, how that could be such a positive for a family, several family members, a person living with dementia to be able to say those words. So, all right, so how do we get a diagnosis? Well, usually people start with their primary care provider. And oftentimes, people get referred to these types of specialists, most commonly a neurologist who, is a specialist in the areas of the brain and how the brain is governing systems throughout the body. And sometimes they're being referred to a geriatric psychiatrist, who is a person who specializes in psychiatry with people that are older who may have dementia and may have other health conditions as well too. Geriatric psychiatrists are a great resource. Neuropsychiatrist is somebody who really specializes very specifically with how the brain is responding and reacting. And then we have our neuropsychologists. They are sometimes used for further testing to be able to really kind of pin down what is happening where in the brain. And then there are geriatricians. Unfortunately, not too terribly many of them, so kind of few and far between. But once in a while, you may encounter one or be referred to a geriatrician, which is a medical doctor that specializes in geriatrics. So what is going to happen in a workup with a referral to a specialist is going to be just the things that we would expect. You're going to get medical history, they'll do a physical, they'll do blood work, lab work, neurological exam will occur. Some of this neuropsychological testing may occur just again to get a better idea of how the brain is functioning, what's going on where. Imaging, brain imaging is often a part of the workup as well too, and interviews with others. Now, why do you suppose interviews with others are important? What do you think? I'll give you the answer. Is because if I'm a person who has the symptoms of dementia and I have memory loss, I might not be able to accurately report what I am experiencing to my physician because of that. So the physician may ask, or the neurologist may ask, well, how's your memory? And I may reply with just fine, because I forget that I forget. And so we do need some corroboration from people that are close to the person experiencing the symptoms to be able to provide, another viewpoint and additional information into how a person is doing. Okay. So we've gone through lots of things here so far, and we covered Alzheimer's disease and related dementias. We talked about the symptoms, and now the risk factors, screening, and diagnosis. So let's just take a few minutes here for some Q&A. And so use your Q&A.
We've got some questions ready here, Jean.
Good. All right.
Yeah.
What we got.
So the first one is about someone whose mother had some surgery a couple of weeks ago. She was on pain medication for several days, and since then she's been sundowning. So if anyone's not familiar with that term, it's a sort of a change in behavior that happens in the late afternoon, early evening hours, more agitation, more disorientation usually. So mom has been sundowning, thinks she is not in her own home, but she is. The question is, do you think this is temporary, or might the pain medications have sort of further messed with her brain, with her cognition?
Well, that's a good question. And I'll give you some thoughts, and I also will just preface it by saying these are also good questions to ask of her physician. Because I do want you to understand I'm not a doctor, so I can't diagnose what's going on. Having said that, I'll tell you anecdotally that many families have reported to us two different things here, is that their family members, if they've had a surgery where they've been under general anesthetic, and this happens with people without dementia, by the way, that there is some of that foggy brain, this symptom of dementia that occurs. our brains are incredibly robust and also incredibly fragile. And, you know, they are impacted, our brains are impacted by such things as surgery and being under anesthetic. And additionally, with pain meds. I mean, if you've already got kind of foggy brain from the anesthetic and now you're on pain meds, that's probably going to affect cognition as well, too. So, you know, my hope is that for this particular lady, that these are temporary changes. It would seem that that may be the case. However, it's important to keep a close eye on things and be reporting these changes to the physician to ensure that, you know, if there is something else going on, which could be a possibility, that that gets attended to.
Absolutely. I totally agree, Jean. And things like after surgery, she's probably, you know, in pain. She may be more prone to dehydration. There's lots of other medical conditions to be attuned to there. Yeah, great. Thank you. Okay, the next question. I think this is a very relatable situation here. I've been diagnosed with MCI, mild cognitive impairment, twice. I feel I have significant memory problems, but all my friends insist I'm no worse than they are. Furthermore, they don't see anything wrong with me. I do know of some who are much worse. So are all of these 69-year-old people affected with dementia? Everyone in my peer group, this person says, claims to be having the same issues. What would you say to that, Jean?
Well, that we could have a whole class practically on that. Mm-hmm. And in a way, I guess we do, because, and let me just say, I'm not going to give a direct answer here because it's a little bit of this and a little bit of that. Just as we talked about earlier, age is a risk factor. So there is a distinct possibility that your friends who are also experiencing memory loss are maybe on the road to developing a dementia, maybe already have these beginning symptoms. And it is also true, we talked about age-related change, and this does occur. Look, I'll be honest with you. Oftentimes with, my friends that I get together with that are my age and a little bit older, we do talk about memory issues. Not all the time, but we're all experiencing some of it. And so is it age-related or is it something else going on? Well, that's one of the very important reasons for this class, is for us to just be aware of what the differences are and to be confident in reaching out to our physicians and, yes, the people around us to do some check-ins. Hey, I'm worried. What do you think? If you've got several people telling you, look, really, you don't seem any worse than the rest of us, for me, that might be enough to reassure me. However, if you're not feeling reassured by that, go back to your physician. See about maybe doing another scan or, further evaluation just to see has there been a change. I mean, it is true that some people with mild cognitive impairment do go on to develop Alzheimer's disease. So I think that's the best answer I can give you, is be empowered to seek out the level of reassurance that you need that's going to satisfy you.
That's a really good answer. Thank you, Jean. This is an interesting question. Is with regard to risk factors for Alzheimer's and other dementias, is diet a risk factor?
Well, over time, yes, it is. The basic premise behind diet and how that impacts risk factors is that, what is good for the heart is good for the brain. So if I eat bacon sandwiches for every meal for the rest of my life, which I might absolutely enjoy, that's going to have an impact on, my body systems, on my cholesterol level, on my heart function, it's going to have impact on all sorts of different things. And these are all risk factors for developing dementia. So by following, the Mediterranean diet is one of the recommended diets to follow. DASH, which is a reduced sodium diet as well too. These diets are all heart healthy, and with a large focus on being plant-based, and reducing saturated fats and such, less meat, less dairy, and they are intended to be heart healthy diets, and we know that that's what's good for the brain. So yes, what we eat affects our health. It affects our lives.
Yeah, so it's sort of this associated risk factor. Right? Eating a diet that's very high in sugar we don't call that directly a risk factor, but a diet that's very high in sugar puts you at risk for other health conditions that are associated with increasing your risk. So the relationship is complicated for sure. Why do so many seniors or people living with dementia, I'll narrow it down a little bit, why does paranoia happen in people with dementia?
Another really, really good question. And I can't tell you precisely why, because I would need to hear that answer from many different people living with dementia. But I can tell you what both my professional experience and I'm telling you my gut knowledge tells me, is that people living with dementia, I always have tried to put myself in their shoes, in their lives, and think about your brain not working properly. And you're trying to make sense of things and you can't remember. I can't remember why I'm here in this room and I don't really know where I am. And somebody's here beside me and they startled me because they came up from behind me and they're starting to, shove food in my face. So maybe what's really happening is my husband has got me up and took me into the kitchen table and has got breakfast in front of me and is lovingly sitting beside me and trying to feed me my breakfast. But because I have dementia, my brain is not able to process all that, and it's become a frightening situation. I don't recognize him. I don't know what this stuff is he's trying to stuff in my mouth. And, the utensil, the fork, it feels weird and foreign, and I don't like the sensation of it. Just try to put yourself in those situations to think about how a person with dementia may be experiencing just a normal daily thing and how frightening that would be. And I think the root of paranoia is fear. And the fear is based out of not knowing or understanding what's going on around them or to them.
Thank you. There are a few more questions coming in. I'm just going to pass one more on to Eugene, and then I think in the interest of time, we'll keep going. But for those of you who have answered questions that we haven't answered, I'll be trying to respond to you in the Q&A individually. So, Jean, what is dementia what does it mean? It sounds like someone's received a diagnosis of something called dementia with behavioral disturbances. What does that mean?
That means that the person has been diagnosed with a type of dementia that is having significant impact in that domain that we talked about, which is personality. It is affecting their behavior. So they maybe become combative, might be suspicious, paranoid, might be agitated. They might be having hallucinations, visual or auditory. There's significant change in their behavior and in their personality that is impacting daily life for the individual and also for the care partner in their efforts to provide care to the person.
Thank you. Okay, let's keep moving in the interest of time, and I'll try to address some of these questions online.
Okay. So we're going to talk about disease progression. I'm going to go fairly quickly through this. But again, do know that, you can put your Q&A in here to Amy, and or you can always call us at Alzheimer's San Diego. We'll give you more information on that too. That's what we're there for, is to answer your questions. So if it doesn't get addressed today, please do contact us and we'll give you that information. So progression, for most dementias, the progression of the disease is slow and steady, and it's a slow and steady decline over time. And you see we've got our little chart here that's showing function here on the left-hand side and time on the bottom. And just over time, as people are going from the earlier stages of the disease through the course of it, it's just, as you see, this kind of wavering line that does go down. And the reason for the bumps and the wavering is simple as for all of us throughout the course of our lives, is we have good days and not so good days, and good weeks and not so good weeks, and months, and just over the course of time. That's how our lives are, is a little bit up and down. And that doesn't change for our folks living with dementia. So the symptoms and severity are difficult to predict, because we are all different people with different health conditions, different resources and supports available to us. So this is why we see, variability in terms of how long does this go on. But we can give you just this kind of generalized idea of it may be 2 to 20 years from time of diagnosis. That people are living with the dementia, the disease that they have. And just take that all with a grain of salt. And, I think the focus, which we can help you with, is to live those years, live that time in as positive a fashion as you can. So I think focusing on the quality rather than the quantity. And that's really actually true for all of us. And we don't know where the end number is. So let's focus on the quality. So yes, the next slide is that diagnosis does not equal incapacity. I get diagnosed today with dementia, Alzheimer's disease. Doesn't mean I don't have decision-making ability and, perhaps still full autonomy over my life. It doesn't mean necessarily that my driver's license is taken away today, or I'm not able to make financial decisions or other decisions of importance. There is opportunity with early detection and diagnosis for me to be very much in control of my life with a diagnosis of Alzheimer's disease. And again, importantly, to be communicating my thoughts and wishes and desires moving forward when such time as my ability to communicate that information is impacted. But it's not a one-up. It's not diagnosed today and incapacitated today. So the stages of the disease, in the early or mild stages, predominantly we're seeing that short-term memory loss for most people with dementia. So it's just that rapid forgetting, not able to remember that we talked on the phone this morning, or that you visited yesterday, or what I had for breakfast this morning. Just that short-term memory loss. We do see some confusion or disorientation, and that may be happening a little bit more so in environments outside of maybe the home, kind of outside of, I guess, what we would term maybe our safe zone. more easy to get lost and confused. I think when I'm talking about this, I often think of a family I worked with some years ago, and the gentleman was, really what we would call early or mild stage of dementia. And he and his wife were in Costco, and he went off to the washroom, and she kept moving around shopping, and he came out and he was disoriented, couldn't find her. Thankfully, he had the wherewithal. He just went out and he went to their car. He did know where the car was parked. But, that's an example of just get some disorientation. But I also just will say, who doesn't get disoriented in Costco? I do too. Problems with some of the what we call the instrumental activities of daily living, which is driving, managing money, meal preparation. Some of those more complex activities are maybe starting to be a little bit more challenging. In the middle and more moderate stages of the disease, we see some communication being affected with language and communication challenge, as well as this increase in memory loss, confusion, and disorientation. We're also seeing people starting to have difficulty with the basic activities of daily living, with a particular emphasis on personal care. And so by that, I mean, we may be seeing people paying less attention to detail when it comes to personal care. So that may mean teeth don't get brushed or not brushed as well as they should, or shirts don't get changed. They've got food and, say coffee drippings down the front, and people aren't aware of, they're not seeing that, they're not aware of it. Less attention to body odor, maybe not showering or bathing as frequently as they need to. So we start to see some changes there. And we are starting to also then see safety concerns in terms of supervision and wandering. People are starting to need more oversight and more direction in this area of middle or moderate stage dementia. And in the late and more severe stages of the disease, we do tend to see limited verbal communication, but that's not always the case. There are some folks who do remain able to do some verbal communication in the late stage. Folks at this stage do need 24-hour supervision and assistance. They are dependent on others for all aspects of care and daily life. We often see problems with chewing and swallowing at this point in time, and reduced physical activity and independent mobility. Some folks may be bedbound by this point in time, although again, that's not everybody, but it is much more impacted. And it's important to also note that throughout this whole process, throughout all these stages of dementia, people that are living with a diagnosis of dementia can do all of these things, make and communicate decisions, even in the late stages. They can be communicating with us through nonverbals, through facial expressions, through the eyes, through squeezing of the hand, through all sorts of things. A food I don't like, I may be going like that, or that I don't want it right now. Maybe I'm not hungry right now. So we have to, as the people who care about and live with people living with dementia, we have to be open to learning how to adjust and change our communication as we go along with our folks as the disease is progressing. People with dementia can still express their feelings and respond to emotional connections. There's no question about that. In my mind, I've seen it. I've worked with folks through end stage of dementia, and the things I think that make us who we are, I think much of that remains. So, it's in there, it remains. And, there's things I think we can do as care partners and professionals to help make those connections with folks. They can engage in modified work and recreational activities, particularly so in the early and even in the middle and moderate stages. We just need to be creative in how we approach these activities for our people living with dementia. And for sure, folks can connect through sensory and nonverbal communication. That is an absolute. So we talk about things that change and that are losses, but let me tell you, much remains. And the human connection, however you choose to view it, the soul, the seat of who we are is there. And I stand by those words.
Mm-hmm.
Symptom management, we're going to do a run through that as well too. And so we'll start with medications. For any of you folks who were at Date with a Cure on Saturday, where Amy was moderating and we had a panel of research, Alzheimer's disease and dementia researchers and doctors, a question was asked about one of these medications, and it was Aricept. And the question from the attendees was, does it work? And the answer was, yes, it does. The clinical studies have, provided the evidence to show that this medication works, and this is true of all of these medications. And there's some important caveats to that as well too. And that is that, as we mentioned before, starting any of these medications earlier is better. It has more time, greater effect and impact the earlier they're started. And that these medications are time limited. They don't change the course of the disease, but they may delay the progression of the symptoms, okay? So what are they? The top ones, as you see, the cholinesterase inhibitors. So that's affecting one of the chemicals in our brain. It allows the brain cells to communicate a little bit better by taking these medications. So, and they are donepezil, which is known as Aricept, rivastigmine. No, I never say that one right.
Rivastigmine.
Thank you.
Yeah.
Exelon.
Call it Exelon. That's easier to say.
Yeah, I'll just call it. It's a good thing I'm not like a pharmacy salesperson or medication salesperson, because I don't think it would be a good career for me. Galantamine, I can pronounce that one. Razidine. The glutamate regulator, memantine, is Namenda. So it operates on different chemicals in the brain, different areas. And then there's a combination medication that is the combination of the Namenda and the Aricept, and they call it Namzaric. And it's time released, so extended release. So there are lots of folks that don't go on Namzaric, rather they take the Aricept pill and the Namenda pill. It just depends on, what your doctor thinks is going to work best for you. And in some cases also what your health insurance will cover. Namzaric, is my understanding, is more expensive medication. Mm-hmm. So that's our medications. And well, what else do we need to do for symptom management? Well, adapting to a new normal. And this is important. I could talk about this for quite some time, but I don't have the luxury of time today. So, but I want you all to think about it very carefully, because here's the thing. How many of us became instant experts at utilizing Zoom over 2-3 days at the start of shelter in place? Not me. Just look at me trying to advance slides still. It's like, I gotta press that need help button. Same as people, become new parents. Did you become an expert new parent right away? No. So you've got a new diagnosis of dementia. Do you become an expert overnight? You don't. You need guidance, you need help, you need information, education. So reach out, think about all the resources that you have at hand. And if you don't know what they are, you've started with us. So let's continue the journey. We can help you with that. There's all sorts of things that folks need to do, and this is just a few of them, and it's just a wee taste. So we want to address the physical and emotional needs. We want to look at what we can do to make the environment a more supportive environment. We want to validate everybody's experiences and emotions, whether we're care partners or family members or people living with the diagnosis. This is a change that affects everybody in that family unit, that relationship unit. Sometimes we need to redirect attention or activity as well too. So there's all sorts of communication changes that essentially care partners and family members need to make. But there are some that people living with dementia can make as well too, to ensure more positive and hopefully clearer communication. And we've got a class completely devoted to that actually is coming up in July, on July 16th. And if you haven't been to that before, I really strongly encourage you to attend that class, that webinar. We need to simplify things. We need to adjust our expectations of our person living with dementia and of ourselves, and we need to address care partner needs. This is a new normal. It's a new day and a new life that is unfolding. And so we need to, be flexible and open and adapt to the changes. So we actually have a little stop for questions, but in the interests of time, because it is coming along here, the clock, I think we'll just keep going.
Okay, sure. I'll keep answering I'm answering in the Q&A, everybody. So for those that Jean hasn't been able to answer live.
Yeah, and I'm going to go fairly quickly through these next things. With planning, we want to talk briefly then about safety, well-being, and support. So safety, this is an very important area, and we do have a class, a webinar devoted to safety considerations where we'll go into more detail with it. But here are the areas we want people to be thinking about. Fall prevention. Remember I mentioned earlier, because of the changes in the brain that are affecting people physically, that people living with dementia are more prone to tripping and falling and having a loss of balance. We want to talk about avoiding injuries and medication errors, especially medication errors, because if I have memory loss, maybe I forgot that I took my medications this morning, and so I go and take them again. And or maybe I completely forget to take them. So medications are an area that's ripe for error and needs to be thought out and addressed. We want to think about abuse prevention, because clearly we know there's still all sorts of bad criminals out there that are willing to do all sorts of nefarious things to access our bank accounts and our personal information. Driving is a complex activity, and at some point in our lives, and this is true for all of us, we will either have to willingly give up our keys and stop driving, or the DMV and or our police service will come in and impound the car or take the keys away from us, or our insurance company will not insure us anymore. So it's important, and we need to think about it, and we need to think about it within the scope of dementia as well too. And the same is true for firearm safety. Lots of people in San Diego have guns. We are a military county, a military town, and there are others beyond military that also have firearms. And it's something we need to think about within the context of dementia. Caregiver stress is a biggie, and we want to give you all the tools we possibly can and all the supports we possibly can to be able to try and mitigate some of that caregiver stress. And wandering is an issue. It's an issue for a majority of people with dementia, that at some point in time they will wander and become lost. So that's another safety concern. Some local safety resources. include Take Me Home. This is a program run through the Sheriff's Department here in San Diego. There's no cost to it, it's free. If you go on the website that is listed here, the URL is listed. It's just a matter of filling out some information about yourself and the person you care for who's living with dementia. And it's registering them in this program so that if your person with dementia were to wander and become lost, you don't know where they are, you call 911, you let 911 know that your person has dementia and has wandered and is missing, and that they are registered and Take Me Home. And so then law enforcement coordinates with each other to put out that alert to all the patrol cars in your area where your person has gone missing to be looking for them. And it's a terrific program. It's award-winning nationwide. It's a model program for other areas. Medicalert Foundation, again, you can go, this is actually our website in the safety section to get information about Medicalert. This is the one where people can wear either a bracelet or a dog tag, or there's other forms of identification that identifies them as being memory impaired and has a number that says to help call. There's a 1-800 number. And through Alzheimer's San Diego, we are able to scholarship your first year of participation in Medicalert. And there's us. There's our Alzheimer's San Diego website, again on the safety page. We have referrals to GPS systems and all sorts of other resources. We do have a free gun lock program as well too. We have a partnership with a local gun range, and they provide us with these gun locks that we can get sent out to you folks as you need them. So think about that. Preparing for the journey. Again, I don't have enough time to give this everything it really deserves. But again, let me just reiterate that we don't become experts in dementia care overnight. It takes time. And there is costs to it for all of us in terms of our physical, emotional, and financial health. And there are demands on these things. And so all of these things are important to be able to have the education and the skills to manage situations to the best of our abilities, to build strong supports and get some regular breaks, to tend to physical and mental health care needs, and hopefully to, as best as we can, maintain a sense of humor. So it's never too early to start the conversation in all of these areas. Advanced care directives, I've referred to this a few times. You know, people who with early diagnosis need to be able to voice their thoughts and opinions and you know, be directing their own plans moving forward in as much as possible. We'll talk about these areas of home and personal safety, driving, financial planning, support systems, and maintaining your health. And we have webinars in specifically many of these areas. So with that, I will again direct you in our next slide to just see at the top is our website, www.alsd.org. And you can have a look at our online education to see what we've got going on coming up, and also what's in our growing library of our online webinars. We have supportive counseling as well too for folks that are needing a little bit more one-on-one. We have virtual support and discussion groups going on. I'm not sure how many we have right now, about 24. Does that sound about
25,
right?
I think.
25. Which is a great support to you folks who are care partners. We have virtual ALS companion visits. I'm going to talk about that in a bit more detail in a minute. We have some social activity programs with movement and motion And that's for our folks with dementia and their care partners if they wish to join in. It's virtual and they're doing some fun things. We have masks. If you need them, we can send them out to you. You just need to give us a call. As always, we have our volunteer tech team. And so again, some thanks to Jamie here for joining us here today. And just please know, if you don't already know this about us, we are a 100% local nonprofit. So we are proud to be a part of San Diego and supporting the community of San Diego County. Every dollar that we do in terms of fundraising stays here in San Diego to support our programs and services to our community. And all our programs and services are free of charge. We got a little shout out here for a couple of programs. Our Virtual Alls Companions program, we're so proud of it. It's so fantastic. Prior to COVID, this program was taking place in person, but it is now gone virtual. And I'm going to turn it over to my colleague, Marcy Hanna, who's going to give us a little more detail and a plug for it. Marcy.
Oh, thanks, Jean, and thanks, Amy. It's so good to be in the class. I haven't been into a class except for as a participant, so it's nice to talk to all of you. We're excited that our Alls Companions Respite Program is now in a virtual format, just like a lot of our other programs, or most all of our programs. We were wondering how this would go, and I have to report that it's going exceptionally well. We have converted most of our Alls Companions families to this virtual format, and we have a lot of new people, and we're hoping that you will be one of them. And so basically we have a similar model in terms of volunteers working with our people who have dementia, doing it once a week, as typical in our other program as well when we were making in-person visits. Sometimes people actually have 2 volunteers, and so having that 2 times a week. What we do find is, and one of our concerns was that you as a care partner wouldn't be getting the respite that you would have with our in-person program. And indeed that is true, it's somewhat. However, what we are really pleased to know is that that is happening, that there are opportunities for you to get a break in your home. And so in this particular program, we use Zoom. It's very similar to what you're doing today. We also, people will do it FaceTime, and then another format that I'm not familiar with, but it's called WhatsApp. And so some people use that as well. So the application process is super easy. You would just call our office, say that you want to be part of this program, and we hope that we get flooded actually by your calls because it really is super good. Part of my challenge today is not to go crazy and start using all of my passion and talking about the program, because I could take up every last second of what's available. And so I don't want to do that today, but I just wanted to tell you that this program has made a lot of impact in the 3 months that we've been doing it. So if you have further questions, you can call our office, talk to one of our social workers. Jean and Amy, is there anything else that you were hoping I would cover today about it?
Nope, I think you got it, Marcy.
Okay, well, give us a call.
Thank you. So that was our virtual Alls Companions. I'll just do a quick plug for our Take Charge program, which is a fantastic education and support series for families, you know, learning to live with a new diagnosis. So what I would say for interest in Take Charge is just give our number a call. You can actually just ask to speak to me, and or you can email me, and I'll be happy to tell you more about that. As always, you can visit our website, you can call, you can email, or you can live chat us. You can also fill out a request form. Amy will send out a link to the request follow-up form in our chat today. And just know, you know, we're answering the phones, and we're on live chat and email Monday through Friday, 8:30 to 5. We're here for you folks. Come reach out to us and utilize our information and supports that we have for you. We've got a slide of trusted websites for more disease information. These are, we just want people to be savvy consumers of information that is out there. So you need to be careful about where you're accessing your information. And these are all trusted websites. So please keep this handy somewhere with your important information regarding seeking out information on Alzheimer's disease and other dementia and other disease information.
And just a quick reminder, we will email these slides out, so you'll have this list in the handouts.
Terrific. And lastly, we want to ask you, if you would, you'll be sent a link to an online survey, and we appreciate you taking your time to fill that out. It's anonymous. We don't know who it's coming from, and it gives us important feedback, how we can tailor and make better our programs that we are offering. Yes, you'll get an email copy of the program, and just be aware of some upcoming programs that we have. This coming Thursday, Living with Memory Loss, and next week, Preparing for the Late Stage. And I thank you all, and we'll stay on for a couple of more questions here. We've gone a little bit over. So if you need to just go, that's completely understood. And if you have questions, but you don't have time now today, again, please call our office or email us and we will respond. Thank you, everybody. Take care. I hope you're all doing well. We're continuing with our shelter in place. We care about all of you, and we're here. We're in this together, folks.
That's right. We really appreciate your participation and your patience with our technical difficulties. We're all we're all feeling our way through this all the time. So it's challenging, and we know it's not ideal, and we look forward to a day we can all be together in the same room again. But in the meantime, we're delighted that so many of you can participate online to be able to reach us this way. Please fill out that survey if you would like to have a social worker reach out. It's confidential, so your information will be kept private, and one of our social workers will reach out to you in whatever method you prefer. So we are happy to provide that support if you need it. And yeah, as Jean said, we'll hang on here for another minute and maybe address a couple of these last few unanswered questions. But thank you for attending today. There's a question about managing resistance. I'll just make a little plug. We actually have a class called Managing Resistance. You're not alone. That's a very common challenge. One of the behavioral disturbances that Jean was talking about, resistance is way up on that list. So we actually have an education program on this topic. The top of my head, we'll be doing it this summer, but we have a recording of it in our webinar library on our website. So you don't have to wait until the next program. You can watch a recording of that, or give our social workers a call or fill out that request form, and somebody can sort of talk you one-on-one through that particular challenge. And
I think that also applies to this other question about what services can I reach out to for support to get my father to take blood lab work and a memory test. He's becoming a person I don't know how to deal with anymore. Similar kind of thing, resistance, and the communication skills class would be great there too.
Agreed. Great. Okay. Well, I think that's a wrap. Thank you all for your participation, your really great questions, and your supportive comments. We appreciate that. We loved having you, and we'll hope to see you at an upcoming program.
Terrific. Bye, everyone.
Bye-bye.